Hello and welcome to Everything End of Life with me, Jason Cottrell, and guests. And today, my guest is Maxine Last. Max, hi Max.
Hello, hi.
Hello. And your title, your present job title is, I've forgotten, I just had it, we were just talking about it. Project Lead, Care, End of Life Care. Okay. So, yeah, tell me a little bit about that, and then we'll talk about your journey to how you got to where you are now, what it is that you actually do.
So, starting with what my role is. So I'm a clinical project lead for End of Life Care, and within that role, it's very varied. I work within the hospital settings at East Suffolk and North Essex Foundation Trust, and so we span community nursing as well as our community hospitals and acute hospitals at Ipswich and Colchester. I have the privilege of being involved with projects in all of those areas, and I also line manage our wonderful butterfly service who support dying people in our hospitals by the bedside through volunteers who give their most precious of resources of time, and that is really, really super important, especially at the end of life.
Absolutely. So let's do an immediate split. So end of life care, very different to palliative care. So yes. When I was working for the hospice, I was a carer in end of life care, which was the last 4 weeks, and more or less the last 4 weeks. But palliative care is, do tell.
So palliative care is the support to people over however long. So it could be right from the very start of a diagnosis with people who have serious life-threatening or life-shortening illness, and to help people to live as well as they can up until the point of dying. So that could be with physical symptom control, that could be with emotional support, counselling and things like that. It could be spiritual support and things like that. So it's much broader, and it's sort of an umbrella term that end of life care sits within it. So end of life care is also varied in that in the community, end of life care is very much viewed as the last year of life or the last phase of life. And so the last year of life, we try and preempt and prompt people to think about, would you be surprised if this person was to die in the next 12 months? And that is sort of, one way of identifying that sort of thought. Within the hospital care settings, and like you say, within the hospice care settings, it's much more focused around, as you say, those last weeks and days of life. But essentially, we still want to be identifying and recognising those people who are in their last year of life as well.
Okay, well, I'm just going to give the book a plug.
Go for it.
I have a copy just as and then here it is. Look there, really unprepared today, clearly. So it's when I joined the hospice as a carer. It was because of COVID and because nobody wanted cooking oil, and that's my mainstay business, is being a cooking oil supplier. So I went back to the nursing side of things and became a carer. But I was so amazed about the work that you folks do, and in that last 4 weeks, I just had to write a book about it because it was a side of life, as a former charge nurse, I'd never seen and I knew very little about. And I think that's very telling of a lot of nurses, doctors. We're very good at trying to get people better. We're not really that great at understanding when that time is coming to an end.
No.
So the book I wrote was called The Last Kiss, Not a Romance. You can find it on Amazon, so there you go. And it covers 15 visits of what it's like going into people's homes and their stories, really. So, and the stories that you will have come across will have been wide and varied, I have no doubt. So let's just jump out of the narrative for a moment and go right back to the beginning. How on earth did you get into this line of work?
Well, back in school when I did my health and social care, that I actually ditched halfway through A level because I thought it was an absolute load of rubbish. I told myself, I'll never be like working in a care home or anything like that. And then naturally, I ended up doing that. So home life was quite turbulent for me a lot of the time. My parents did struggle with alcohol use, and it was. It could be quite difficult. Yeah, it could be quite difficult at times. So I did leave home fairly early and I became a live-in carer. I just took an opportunity that presented itself. And so I became a live-in carer. I was just turned 18.
Turned 18 and straight out of not doing health and social care at all.
No.
Straight into becoming
having
carer.
said that, whilst I was a teenager, I was very much acting as mum to my
Right.
younger brother and sister for a
Of course.
large number of years.
So you're actually living health and social care basically already.
Yeah, so I've always wanted to help others, and primarily that was born out of helping my brother and sister and myself to cope through some difficult times. So I kind of find it quite natural to be there for people, I suppose, and be the person that they would like me to be at that time, what they need. So I was a living carer for a lovely lady called Mary, and she, after 3 years, died in her sleep through a heart attack.
Okay.
And I found her in the morning, and I was only like 21, and yeah, she'd been dead a while, but
Yeah.
that was the first time I'd seen a dead body,
Really?
and certainly, like, obviously I'd grown to love her, so it was.
Really hard.
Yeah, anyway, the paramedics, when they came in, were like, step away from the body, leave Mary to rest.
Yes. That's just the
So,
first
but
time you've ever seen that. That really is,
yeah,
it's phenomenal, isn't it? And I think for a lot of people, actually, even though you've seen a lot of that since,
oh yeah,
up until 30, 40, 50 years old, quite often nobody has seen somebody else
no,
die, in...
no. And it's really important, Jason, to say that actually, in most cases, dying follows the sort of a natural process. And there's a really good video by Catherine Mannix that
Oh, yeah.
anyone could have a look, just to plug that. I think just from an educational perspective, it's a really gentle way of explaining what normal death looks like, what
Yeah.
most people go through, and that it is a very natural process. So, but obviously my line of work now has sort of like gone into the more sort of more complex death and dying, whilst also supporting those more natural deaths also.
Yeah, that's brilliant. I mean, I was lucky enough to have Becky on a little while ago. So we went through that last 4 week stage of slowing down
Yeah,
and the markers that you start to see of losing appetite, not wanting to
absolutely.
drink, getting tired and sleepy. I mean, and it's okay. And for 99% of us, I think it's not that bad a thing. It's just, I think none of us want to leave the party,
No.
And that's especially at our age. Well, your age, you're half my age, but at any age really, I kind of don't go gently into the night. Actually, I think no,
Yeah.
do go gently into the night. It's much nicer than struggling and
And
fights.
yeah, absolutely. I think none of us know when it's coming to us, and we're of an age where we see so many young people being diagnosed with various illnesses, not just cancer related ones, that are likely to shorten someone's life. And I think, whilst there's loads of advancements to try and keep people being treated and potentially curing things, that's not always possible. And so we all I know for myself, like knowing that I've got a will and lasting power of attorney sorted, knowing that I know who my funeral directors are and things like that, brings me comfort, because I know my family aren't going to have to worry about it, and my friends and you know um my partner aren't going to have to worry about any of that if I get hit by a bus tomorrow and they don't know what to do. There's no scrambling about. So, and I think if we were able to live in a world where everybody had, wherever possible and whoever felt able to be signposted to that kind of
Be organised.
mindset, to
Yeah,
yeah, just to get it done whilst you're well, whilst you don't have to worry about anything else. Then when you're really unwell, you can focus on what really matters, because you've already planned ahead and thought about those things that, you know, in an emergency situation are the last thing you want to be thinking about.
absolutely. I was talking to Shawn Leek, the mental health runner, about this. And he's a lovely guy. So, and
He's great.
we were saying the same kind of thing. It's being prepared, being organised. It's there's a thing where we say to each other, "Oh, people don't like talking about death," but I don't think that's really entirely true, because it's quite
Mm,
academic for us unless we're faced with it. I think
yeah.
we don't like talking about what's going to happen way off in the future. Just as I'm not going to, I was saying to Shawn, I'm not going to be worried about organising the holiday I've got in 10 years' time, because it's in 10 years' time. And
Absolutely.
and we all think it's going to be in 10 years' time or 20 or 50 years' time, So, yeah,
Absolutely. But the thing is, with death and dying, that is one thing that is certain. The same with losses is, you know, inevitably going to happen to all of us through, a relative dying, or a close friend, or a neighbour, anyone. So we're all affected by death, dying and loss all of the time, but we
Go on,
don't know when.
we just got really sidetracked there. There you were with Mary.
Oh, sorry.
No, it's my fault. I went off on a tangent, I think. And the paramedics came in and said, step away from the body. That's where we kind of left off. So let's
Yes,
get back
sorry,
to
yes.
That's
Yeah.
right.
So Mary had died, and at that point I needed somewhere else to live. So I relocated to Ipswich, and so I've never really strayed too far from Suffolk. And where I had found to live was very, very close to St Elizabeth Hospice. And so I took that opportunity to apply and see if I could start working there, because it kind of, with Mary dying, I think it lit a flame within me to know that I could deal with that kind of scenario. Now I feel like I can do this. So I joined the St Elizabeth Hospice and I stayed with them for 5 years, and during that time I did my nurses training. I absolutely loved working there, but whilst I was doing my nurses training, I fell in love with the hospital care setting, that busy, fast pace, but also still within me thinking, how can I make end of life care in hospital the best it can be, considering they're not at the hospice, or whilst we're trying to get them home, and those sorts of scenarios. And equally as well with palliative care, like, how do we break bad news and how do we make that better for people and their loved ones? And, most of the time it's down to communication and how we do that, and making sure that that is actually done in the first place, and being honest with people when they want to be, told honestly about a situation.
Yeah, I mean, and that's difficult conversations to have, isn't it?
Very difficult.
And yet, as I was saying with Becky, she had a particular conversation with a fella who didn't want to have a DNAR, but he was getting really close to the end, and she was trying to explain to him, well, if you do have resuscitation, it's not as pretty as it looks. It might leave you more damaged than, and these are things that are quite hard to hear, but best to be said if you can couch it in the right way, because then he understood that his wife might be left looking after him in a really poorly way, instead of just the poorly way he was. And you're right, those conversations, and I think, when you've worked in this field for a while, the conversations get a little easier, but not for the recipient, So,
No,
No,
it's very important to remember that.
I love seeing people have that conversation, because it's beautiful in a way to see how well the professionals go in there softly and do it really beautifully. And that's not always the case, because I remember my GP saying to me, well, your mum's probably got about, the weekend to live, and that's the end of it. I went, oh, okay. And then he went off to play golf, and he was just telling me about, well, I don't know if he thought he was just trying to soften the blow that way, but it's like, your mum's going to die, that's the end of that. So I don't think we always get the best bedside manner from people, but if it's a repetitive industry like worked in the hospice, you know what to say, and you know how to couch it. I think that's a beautiful thing to actually watch.
Yeah, and it's how we best share that with others, so that our clinicians and, all our colleagues know how to sort of approach those sorts of conversations with a bit more confidence in their abilities, and really not underestimating the importance of listening to somebody and just allowing time for information to be processed, and just not rushing into something, like just taking a bit of a step-by-step approach. It does always help to have a bit of a warning shot as well of information. So, to start on a conversation with, I might have some bad news to give you. Is there anyone that could be with you, for when I sort of come back? And those sorts of little warning shots are really useful.
So there you were. I've done it again. Sidetracked you, and you've done your nurse training.
Yep.
And you've chosen what sort of area to work in, because you don't necessarily have to stay at the hospice, do you?
Well, so actually I did get a lot of say where I went, and I knew that I wanted to be somewhere very general, because I just love everything. In fact, a lot of people say you're either a surgical nurse or a medical nurse, but I think I'm an everything nurse. I love every single bit. And I could have quite easily have gone into theatre to be a scrub nurse, but I ended up choosing a medical short stay unit, which I absolutely loved. I used to say it was organised chaos. And I am a very organised person, so it fitted me perfectly, and it was very fast, and so many different conditions and things coming in that we were treating and supporting, and the team on the ward that I was on were just phenomenal. And then, but I was a link nurse on there for end of life care naturally, and kept still being drawn back to that every step really. So pursuing a career that was around end of life care in some way, or palliative care, was always where I was going to end up. And so it was just navigating the stepping stones. So I didn't take the traditional route of spending loads of time within a hospice care setting. And I actually found it an advantage to be within the acute medical sort of area of care to where I am now. So a job came up with acute oncology, which I thought, having some cancer experience is probably not a bad shout. But I didn't want to pigeonhole myself into working on a cancer or oncology ward. Although I had done some additional shifts, like bank shifts they call them, on that ward, the oncology ward, and some other wards around the hospital, like care of the elderly and gastroenterology, looking at, abdominal tummy issues, stuff like that.
So you're getting a wide experience.
Absolutely. Yeah,
That's so
because
important.
like any one of us could, require end of life care for any number of reasons. It's not just cancer. There are so many non-cancer related conditions that are
Yeah,
absolutely just as deserving of having good palliative and end of life care. So, and it's
yeah.
probably about a 50-50% split
My sister was
currently.
went down. She went down with COPD, and she had that thing where she got ill and then went down a bit, and then
Yeah.
didn't quite come up to where she was. Got ill, and that travelled that down over a few years, and that was complicated by the fact that she wouldn't give up her fags. So she was
But it's patient
stubborn,
choice,
happy.
and if that
Yeah,
has brought quality to her life, I know there's an element of trying to promote healthy lifestyles, but equally, if you're being faced with your last year of life, at the end of the day, it's what's important to you, what matters
definitely.
most to you, and
Her role
sometimes,
is definitely what mattered to her.
yeah,
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 so she loved that. And
yeah,
she was never a great one for exercise, but she was a great little artist. So she would sit and smoke and paint and
that's lovely.
yeah.
That's
She just
so
went slowly
nice.
down. That's bless her.
Yeah,
Yeah, and was very inspirational to quite a few other artists as well. So which was lovely.
yeah.
There we go. So then you're in the hospital setting. How did you get from there to here?
So acute oncology, I stayed with them a little while. So we visited wards in the hospital and sort of triaged patients that were having acute cancer issues, either relating to treatment or their disease or their condition deteriorating. And so that's where, again, I was using my passion for good palliative and end of life care, making sure that palliative care referrals were done early and being able to facilitate that discussion change from active treatment to this is no longer curative, but this is what we can do. So there are still things we can actively do, but it's not going to cure you from the condition that you have. And then a job came up with the palliative care team, the specialist palliative care team at Ipswich, and I absolutely seized that opportunity, more so because I wanted to make sure that they were aware that I was interested and that I had an absolute passion to be within that area of care and to remain within the hospital doing that. And to my absolute surprise, I just about got an interview and then went to the top of their list and was handed the job, and I was absolutely gobsmacked and just couldn't believe it. But the difference that I feel that I've made to people's lives in the time that I was a palliative care CNS is immeasurable. The team and all specialist palliative care teams will know just what sort of complex situations that we're invited to support and give recommendations and just help in any way that we can. And it's just an amazing feeling to be able to help somebody from one of the darkest moments in their lives to bring a little bit of light to a very dark place.
Do you know, that is really well put, because one of the things, and I've talked about this before, one of the things that was really lovely when I was doing caring, because we'd go in the morning for an hour with somebody, and then to help them get up, and then an hour in the evening to help them, get settled for the night. And when we'd go into some places, there'd be one relative had been looking after someone for ages, and their shoulders would be up here, and they'd be, oh, I don't know what's going on. And then because they then knew that there was going to be somebody coming in to support them in the morning and in the evening, they weren't on their own anymore. And there's a wealth of expertise, and there is single point, which is somewhere they can contact 24 hours a day. Their anxiety levels would just kind of sink. And by the time we went in the evening, they would be coming on, yes, had a good day, would you like a cup of tea, shall we have a chat? And it's, to watch that transition so rapidly, it gives you such a great feeling. And, you must get that all the time by seeing the change in people and also helping them through those really difficult moments.
Yeah, and it's building rapport with people and being a advocate for somebody and being a person that they can come to and know that they're met with no judgment and know that they're being taken seriously and their concerns are going to be escalated if somebody else isn't doing that. I think, I really take pride in being an advocate for my patients. And, when I was certainly in that role, now I really, really, really value being an advocate in a more broader sense of the term, but also for our colleagues to highlight all the really good stuff that's going on with end of life care in our hospitals, and lots of initiatives and projects that wards are leading on in response to previous poor end of life care experiences that might have been had.
I mean, it's fair to say that when you go into hospitals, quite often outside of the ward, they'll have what are we really good at and what do we have to do better at. And quite often, end-of-life care will be that, what do we have to do better at? And that will be on the outside of the ward. I've seen that in a few hospitals. And, I wonder sometimes how do you make that better? How do you identify why it's not as good as it could be?
I mean, it's such a difficult question, that one, because it's got so many different variables as to what's impacting that particular thing. And it could be a particular person, it could be a difficult dynamic, it could be a particularly challenging situation, it could be just on that particular day they had short staff, or it could be on that particular day that a relative was maybe unhappy for some completely unrelated reason, and it just takes one downfall to make the dominoes fall. And so it's important to say that actually there's so much good going on, and not to lose sight of that and focus on the negatives and things like that we do have in our hospitals, and to try and create a culture of seeing what's good.
Well, this
and
is
how
part
do
of
we
your job, isn't it? Because, and this is what I've seen, generally speaking, is it's a continual when I see those signs outside. There's a continual striving when you go into that ward and you talk to the nurses there and you say, well, what are you doing about improving and like that? The one thing that always comes up is we're trying to improve our communications at the set.
That I think will always be.
Relatives, it's just always there.
Yeah, I think in terms of communication, it's difficult when you've got like lots of new staff coming in and staff leaving. So you get like lots of really good staff upskilled and things like that. And then you have like an influx of newer staff, and it kind of is a revolving cycle. So end of life care will always be a priority and something to work on, because it always has been and it always should be. Because it's just as inevitable as coming into the world and, delivering babies and such like.
Yeah.
But we try and promote healthy, transparent, honest conversations with people, obviously after finding out their information preferences in the first place. And just telling people, that this could happen. So using a phrase such as, your loved one is so sick they might be dying, sort of softens that blow, as we were talking about earlier, and is a useful tool that we're promoting the use of in hospitals at the moment. And we're seeing it used so much more now, which is absolutely brilliant, that people are being identified as being so sick they might be dying, to try and action that gap, that need for people being identified earlier than the point that they're taking their last breaths, so that they can have all the support available to them and offered to them, such as car parking permits, or a comfort blanket, or butterfly volunteers to sit beside, and for companionship and signposting, and the chaplaincy team, and to make sure that we can prioritise side rooms so that somebody could have a private room. All of those things are born out of being identified at the earliest point that this is what could be happening. Yeah, because otherwise you've just got no time to put all of these things in place. If you're identifying someone, and we within our hospital, acute hospitals, have got a digital platform called Watchpoint Last Days of Life. And so currently that's how we make visible in an electronic format. So wherever, for instance, wherever I am in the hospital, I can see who is dying within the hospital. But that's only as good as the people putting it on there, putting somebody on there at the time to ensure that, patients and their loved ones and their carers have all the support available to them that they need.
So that's going back to that being organised thing, isn't it? And saying, the better experience somebody's going to have depends upon how well organised the system behind that whole area is organised. And I think that's, that seems to be what your main focus of your job is to coordinate and make sure that all of those people are pulling together to make that service, soft at the point of delivery. And
yeah, I suppose so. I mean, I certainly have an influence over a lot of things that are going on in the hospitals. A large part of my job is communicating things that we're doing through end-of-life steering groups. So whether that's within our ESNEFT end-of-life steering group, or whether that's other ones that are, a bit more to do with Suffolk and North East Essex wide, or things like that. I have a lot to do with data collection and reporting, and have influence over sort of, highlighting needs for education and areas that need additional support, and any projects that are up and running that either I can sort myself with obviously lots of people, stakeholders, and collaboration with other colleagues involved too, but then also to support those that are trying to get a project off the ground as well, and to celebrate that too.
Well, one of the projects that is getting off of the ground at the moment is the Compassionate Communities.
Yes.
Initiative that Shawn and Greg Cooper, I think, have put together and been really pushing forward, which is just creating great connections out there between people and identifying people as being compassionate champions, if you like. So It's a little bit of recognition. And you've been quite involved in that, I think.
I have, yes. So I'm part of the network. So the network is sort of the initial group that we were pulled together to achieve Compassionate City accreditation for Colchester, and Suffolk are now starting their journey into that accreditation as well.
Right.
So it's really awesome to sort of see how things are progressing and how different the two are. But yeah, as you say, so Compassionate Communities is all about that 95% of time that people living with dying, experiencing death and loss are not spending with a healthcare professional. So that 95% of the time is spent within the community, with our friends, with our family, with the local shop and the pub, and, our community centres and our churches, and all of these other things, voluntary groups and charitable organisations, and all of that other support that's out there other than just your GP or doctor at the hospital and your nurse specialist and those sorts of things. So we play a vital part in meeting Ambition 6 of the palliative and end-of-life care national ambitions, preparing each community to be able to help. And so obviously our community come into our hospitals. We need to be able to sing from the same hymn sheet and make sure that that information and signposting is given back to the community so that they are empowered to be able to stay at home for as long as possible. And one of the ways in which I'm doing that with the service that I line manage is through the butterfly service, because we are unique within our end-of-life volunteer service that we have centres at Ipswich and Colchester hospitals. So people can just drop in and say hi. They're supporting the last phase of life within those centres. So they can signpost to treasures within our communities, and they can refer as well to services. They've got a lot of skills behind them themselves. So all of our coordinators are dual trained as compassionate companions.
Right.
So the compassionate companion service in the community of Suffolk is supporting people with advanced care planning conversations in their own homes. So my vision for the future is that our volunteers will be able to support, if they feel like they would like to be upskilled in that area, to be able to support with the non-clinical elements of advanced care planning, which is just that human-human interaction of understanding what matters most to somebody. And we can do that just through a cup of tea and, just having a chat, that you'll find out interesting and important information to what matters to that person and their family. So it doesn't need a doctor or a consultant or a nurse to do that. So, but that conversation has to have been started by a clinician, that this is what might happen. Would you like to prepare for that or have conversations that plan for that? Those conversations take time, and clinicians and really busy hospital staff certainly don't have that time to spend what's needed. So the community is where that really sits, is, we need our community to be able to, first of all, know that resource is there, and then to feel able to use it to the best of their ability for their own benefit, and for their family's benefit.
I love this idea of having a bank of people, if you like, that you can call upon. So
Yeah.
Somebody just needs to talk about, what they think their journey might be, what is important to them. Didn't we have in the hospice, I think we had a pamphlet where you could write down what you want your preferences to be, but not necessarily just about end-of-life care, but all the way up to leading to there. And that's an amazing thing. I'll just flag up a little booklet that a friend of mine, lady at a local shop, showed me, and it was an American thing, and it's just a little book, that you can write in, and it's got little titles at the top. Have you thought about insurance? Have you put all your passcode numbers down? Have you, doctors, don't even get me started. It says, have you talked to your doctors about this, that, and the other? And it's really quite humorous, but it's beautifully put together so that you can start thinking about that sort of thing. And something like that, to be able to take that in, to have that conversation and say, it's not happening yet, but,
Yeah, that's it. And there's so many resources like that available.
Yeah.
And I mean, obviously through Colchester and North East Essex, we try and promote wherever possible the My Care Choices register. And that is in the future, it is agreed that Suffolk will also be having My Care Choices register coming across to them, but the timeline for that is uncertain. But that's a really
the My Care.
So the My Care Choices Register is, again, a digitalisation of identifying somebody in the last year of life and shorter, and being able to, hopefully at the earliest point, get them onto the register, and being able to see what matters most to that person, whether they want to, for instance, be at home for their death or primarily for their care, or whether they would prefer to be in a hospice, for example. Some people do choose to die in hospital as well, so it's important to note that. And so it's just sort of making those decisions visible to not only the hospice who host the platform, but also to hospice, to GPs, to community nurses, to the ambulance service. So anyone who is caring for that individual can check that register to see what somebody would have wanted, or just check that it's up to date with what the current situation is with their condition, and whether they've had a significant deterioration, and making sure that that information is still relevant and correct. And that could, it's hoped that prevents people from coming unnecessarily into hospital, because they've got their preferences clearly documented and understood by anyone involved in their care.
I mean, it's an amazing thing to think that that's actually a linked up thing. People can actually professionals can access it and say, right, John Florida Groats, or whatever your name is, he specifically doesn't want this type of care, he doesn't want to come into hospital. My father-in-law was a lovely fella, and he just didn't want to go into hospital. And and he was dying slowly, possibly over a year in wait, and he didn't want to know what the diagnosis was, he didn't care, he just wanted to carry on his own sweet little way until, for the last 4 weeks, I think I was 5 weeks maybe, I was going up to Sudbury and giving him a wash down, doing his teeth for him. Lost so much weight I could just lift him up the bed.
Yeah.
But that was what he wanted. He didn't want the fuss of a hospital. Some people love the reassurance of having the buzz of a medical staff all around them.
Absolutely.
But that wasn't on any particular register because he didn't want to even have that conversation. So, and it is then looping back, isn't it, to having that conversation. And if we can encourage people to have that conversation years before they're even getting to a diagnosis.
Yeah, it really helps.
Yeah.
You know, because you've already gone over that really difficult hurdle of saying the D word, you know, death and dying. That's sometimes one of the biggest things, is just that fear of saying out loud that is potentially going to happen much sooner than we think or would like it to, you know. And yeah, so just getting that step out of the way is you know, really, really helpful in guiding conversations going forward.
Yeah, I have a friend who's I've known for a number of years, one of my customers, and he's recently, well, I hadn't seen him for about a couple of months, and then I went to the shop to just drop off some oil, and he called me because the shop was shut, and I said, so how are you doing? He said, oh, well, I've got a terminal illness. And I went, well, that's a bit of a bummer. So, and he said, yeah, no, don't worry. He said, apparently I've got about a year, but I don't know, nobody really knows. And you can see his colour had changed in his face.
Yeah.
And he might come on the show, he's thinking about it. And he was so positive. He is such a positive guy. He was saying, well, I don't know how long, they don't know how long I've got. I mean, I can't. You know, I've had a great life, it's been good. You know, I think he's about my age, he's about 62, 63, so he's not an old man by any talk of the mark. He's so accepting of the fact that none of us know, you know, how long we've got, and it's no point in getting all upset and fighting it. For him, you know, for other people it can be different. But for him, it's such a positive attitude. And he's still working his restaurant and things.
Yeah.
Amazing guy. And I must introduce him to my care register, actually. So
yeah, that's a very good idea, just in case, because you just never know when somebody might lose their voice and lose that ability to be able to, I don't mean physically lose their voice. Well, I kind of do, well, but like, really. you know, at a state of where you are unconscious or maybe do not have capacity anymore, those decisions that you definitely know in your heart you want, at least you know that those will be respected as much as possible and are known. You know, because that's one of the more challenging things, is when somebody, you know, like say for instance with dementia or a brain tumor, for instance, where that capacity is sometimes lost, and people just haven't been given the opportunity to be able to explore what they would have wanted. It then falls, as I said before, like onto families, and they're trying to deal with the inevitable loss of their loved one, you know, and their own grief. And you know, being there for that person up until that point, and then, you know, also juggling their own, you know, lives and family and whatever. So yeah, it's just really important that people have their voice heard before there's a chance that it might not be, wherever possible. It's not always possible, we know that.
No, it's not.
And there is so much uncertainty about sort of, you know, trajectory of somebody deteriorating. There'll often be signs, or, you know, like more recurrent admissions into hospital, or you know, things like that. But sometimes there isn't. Sometimes it can all happen quite suddenly and quickly, you know. That's just how it is. But wherever we can preempt, then I think that is something that, you know, can only be of benefit to people and a good thing.
Your job is such an amazing job.
It's very diverse.
I'm going to say, it's all over the place, mate.
Yeah.
How do you keep track of it all?
I was told a lot of workbooks.
Is that how you do it?
Yes.
Brilliant. Well done. God, you were told by someone. Yes?
Pardon?
You were told by someone something, but you were going to just...
Oh, I was told that I could do whatever I wanted with this job, so I hope I'm doing it justice.
Well, it sounds like you almost definitely are. I don't think anybody listening to this podcast is going to go, well, she's slacking, isn't she? She's just sitting around not doing much. What's the matter with you? So, listen, I'm going to sign off by a big thank you for coming on and explaining what you do and that whole area of a difference between palliative care and end-of-life care and the choices and that we've got going on.
I was just wondering. Yeah, I was wondering if I could also do a bit of a selfish plug to something I'm working on at the moment.
Yeah, sure, of course.
So one of the things that I'm working on is an appeal for ensuring that our butterfly service can continue, and that does require £100,000 a year to continue. Okay. I know, right? But we have an appeal that myself and the end of life care team, the charity team here, Colchester and Ipswich Hospitals Charity, have worked so incredibly hard to develop to ensure that we can continue to support for those things that the NHS are unable to provide dedicated funding to. So anyone listening, perhaps if you want to buy like a metal butterfly that's been made by Suffolk Ironworks, or donate it or raise money in any way possible, then yeah, we'd all be super grateful, and you'd be supporting your local hospitals and end-of-life care for yourself potentially and everyone in your community.
Brilliant. Now, so let's get practical. How do they get in contact with somebody to do that?
Just go on Colchester and Ipswich Hospitals charity website, or type in the butterfly appeal into any search engine. Yeah, the butterfly appeal.
Yeah.
Yes.
So Essex and Suffolk. Well, absolutely.
Thank you so much.
No, it's good. I mean, all of these things. It's the crazy thing is if we had all the money in the world,
I know,
the services would be amazing, but we don't.
I know, right? We don't.
Charities,
we have to be creative, and our charity they're incredible. Our charity team. So.
Okay, so go online, look up the butterfly service for Suffolk and Essex, and see what you can do. All right, Max, thank you very much. So much for coming on. It's been an amazing pleasure.
Yeah, it's been awesome talking with you, Jason.
Okay.
Take care.
And good luck in the future. I'll hope to catch up with you soon.
Yeah, absolutely. Take care.
All right. Thanks a lot. Bye.
Bye.